At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live.
All right, good day and welcome. I'm Jeff McIntyre. I am the Vice President of Liver Health Programs with the Global Liver Institute, filling in for our beloved CEO and President Donna Cryer, who couldn't join us today. But I'm really excited to host today and actually talk specifically about these issues today. May, as you may know, is Mental Health Awareness Month. And at GLI, we recognize the importance of whole person health, especially when dealing with an ongoing condition that can affect so many different aspects of patients and, frankly, of their families' lives. And to talk more about this, we are joined today by Dr. Paula Zimbrand, the Director of Transplant Psychiatry and Associate Professor of Yale New Haven Hospital. And you've been there for quite a while. So thank you for joining us, Dr. Zimbrand. Welcome to GLI Live. As I mentioned, it is Mental Health Awareness Month, but we know mental health really takes a back seat for a lot of people. And so I really want to kind of get the conversation started today with the basics. When someone has chronic illness, like chronic liver disease, for instance, we know that they're twice as likely to face mental illness issues or challenges in that. Why is that? And why are patients kind of hit with this double burden, if you will?
Thank you. That's a great question. And yes, it's true. We do see that patients with chronic medical problems, including patients with chronic liver disease, are more likely to have psychiatric symptoms or psychiatric conditions. They are facing several hurdles. One is the medical illness in itself can lead to changes in the body and in the brain that lead to development of psychiatric or mental health symptoms. Another aspect of coping with chronic medical illness, especially in the United States, is the psychosocial impact of the illness in itself. The logistical difficulties that these patients face in accessing healthcare, the time in itself that it's required to access good medical care, and then the disability that comes from medical illness, which leads to social changes for the patient and for the family. And last but not least, some of medical conditions are a consequence of an underlying psychiatric problem, like the classic example of patients who use alcohol excessively and develop liver disease, or that's also sometimes the case.
Right. So your specialization is in transplant psychiatry, if you will. I'm wondering if you talk a little bit about kind of what transplant psychiatry is, and why is there a need for transplant psychiatry, if you will?
So it was very early in the history of transplantation that it was noted that after the surgery of transplantation, patients can develop psychiatric symptoms. And at that time, it was early in the history of this procedure, it was considered that it's an immune reaction of the body to the organ. Later, that leads to symptoms like psychosis or paranoia. Later, we learn more that some of the medications that patients can take can lead to psychiatric side effects, like, for example, steroids or prednisone. And slowly, as transplant became more and more generalized, we learn more about how underlying psychiatric disorders can impact the ability of a patient to participate in the care and to be successful at getting the medical treatment that they deserve. So transplant psychiatry is a subspecialty of another psychiatric subspecialty called consultation liaison, which deals with psychiatric symptoms in patients with chronic medical conditions. And transplant psychiatrists work often, they're co-located with the transplant providers, like in transplant centers. So in the same place where a patient sees the surgical team and receives the immunosuppression, that's where they can also see psychiatrists and oftentimes psychologists who are also involved in this work.
It seems to me with much of liver disease or some liver disease, there's can be such a heavy behavioral component leading or influencing liver disease in some way. And we know there's such an emotional or psychosocial component often to behavior as well. I'm curious about kind of how you would approach this, that you have a patient that is getting ready for transplant, and then also patients that have had a transplant. How do you broach that? I mean, when we talk about, serious mental illness, we're thinking of, you've mentioned some pretty severe mental illnesses, but I'm also thinking in terms of anxiety, of depression, things that could lead to like, binge drinking, et cetera, but also could lead to, disordered eating, things that are frankly covered in the DSM, if you will, more so than things that may just be influencing one way or the other. As a transplant psychiatrist, what are kind of some of the issues you see going into transplant versus some of the issues you would see coming out of it for patients?
So we aim that most of if ideally all patients who are preparing for transplantation meet with a mental health professional to get a sense of, first of all, for a diagnostic assessment, to exactly what you're saying, to tease out the conditions that are pre-existing and what is new, what is caused by the disease. But also a part of this pre-transplant evaluation, we do a lot of preparing the patient. Some education component, some helping out developing coping skills. We help the transplant team inform the patient about what kind of challenges are to be expected. And this pre-transplant evaluation also helps us get to know the patient. So when they develop later in the course symptoms, it's very easy to assess and help them out and with the symptoms that they developed. Post-transplant, we have the additional component of the impact of the treatment in itself. Some of these medications can cause difficulties that may look psychiatric, but they're not psychiatric. For instance, one medication can cause alteration of one's taste, which can impact the way the interest a person has in food, can impact their ability to gain the weight that they need to recover, and can be labeled as a eating disorder, which we might end up realizing that it's not an eating disorder at all. It's a side effect of medication.
Yeah, I mean, that is one of the struggles I know for many patients that are, for instance, that they're looking at a decompensated cirrhosis as a result of NASH and are looking at a liver transplant of some sort for their history of trying to treat NASH for themselves. It's been lose weight, lose weight, lose weight, lose weight. And then suddenly transplant comes along and it's gain weight, gain weight, gain weight. That's a real difficult juxtaposition for patients to try to wrap their heads around. If everything you've been told, ignore that, now do something completely different. Let me ask this, because you dropped a phrase in there that I want to come back to, which is you talked about existing conditions that pre-exist or pre-existing conditions. I'm curious, in your research you've done for patients with mental illness or severe mental illness of some sort, often we know that, as we've said, that can lead to many of the complications around their liver disease. Has that, or what is the relationship between that and transplant? Could it possibly preclude them from transplant? Is there an issue with people just kind of getting caught in the morass of pre-existing conditions that contribute to the disease, but those conditions also precluding them, from being on the transplant registry?
That's an excellent question, and I like to believe that we moved away from the times when having a psychiatric illness was a contraindication for transplantation. Because we've seen people who with severe mental illness going through transplant successfully. We've also learned more about what can help them to be successful in this. We know, so part of the pre-transplant evaluation is to identify what interventions can help a patient receive the transplant and have good outcomes after transplantation. Sometimes there's more education needed. Sometimes they need support with some symptoms that still require to be addressed. Sometimes they need actually a change of medications because there are drug-to-drug interactions. So there are many factors that can influence one's ability to participate in the care, that the complex care that is required by transplantation. But now the field is moving forward towards helping the patient and identifying what interventions are needed, and not as much as keeping people away from transplant.
What would you say the prevalence of mental illness of any sort is for transplant patients, for people that are waiting for transplant, for instance? Are there any studies that talk about prevalence in this way?
There are many studies that looked at the prevalence of psychiatric illness in transplant candidates. It varies quite a bit because the time when one comes for the transplantation evaluation can vary depending on regional or center parameters that have nothing to do with the patient in itself. And also, as they're waiting for a transplant, which can be very long, this wait can be very long and again varies geographically. There are significant variations. An unofficial survey we did at our center, for instance, when we screened all patients coming in for an evaluation for transplantation, about 60% had active psychiatric concerns that required either further assessment or an intervention.
Wow, that's fascinating. I mean, 60% is a pretty overwhelming number for that. Could you give a few examples of what the nature of those conditions would be?
Oftentimes there were depression, anxiety related to the perspective of such a big surgery and the alternative to it, which could be the demise.
Right.
Then many of them have psychiatric symptoms related to the disease in itself. Things like anhedonia, like they cannot enjoy anything, which can equal depression, or confusion. A lot of significant memory problems, difficulty concentrating, that again often are related to the medical disease in itself. And there are some patients with for instance, manic depressive illness in various stages of treatment that we also sometimes see as transplant candidates.
I want to be a little more intentional about asking this question, so forgive me if this seems naive as we go into this, but the flip side of this would be the benefits of treating mental illness, not just severe mental illness, but treating, and working on our mental health in general, but specifically for patients that are facing these difficult and challenging sort of situations with their liver disease. And again, kind of a basic question, but I think, especially in Western society, we've often had this just kind of tough it out sort of mentality around mental health. Brush it off, deal with it. It's always been very not looked down upon, but we're only now beginning to have kind of these broader societal conversations about wellness, about self-care, about understanding depression and anxiety as treatable occurrences for individuals, about trauma, etc. Here's my basic question. What's the benefit of treating these emotional and psychiatric conditions for patients? Is there something, especially facing liver disease or a transplant sort of situation, why not just focus on the liver? What is the specific benefit of addressing these conditions?
That's a great question. Yes. Why should we even think about this in the context of transplantation? There have been numerous studies showing that depression, for instance, left untreated post-transplantation, leads to more complications, such as increased risk of infections, more hospitalizations, longer length of stay in the hospital when patients are depressed. And the mechanism of how depression influences these medical outcomes is not 100% clear yet, but some of those mechanisms include, for instance, a decreased participation in physical therapy for patients who have significant symptoms of depression, which leads with a longer length of stay, a slower recovery, which affects the overall quality of life. So that's one of the main incentive for which we want to address the psychiatric concerns, so patients' quality of life is better and the recovery is faster.
Yeah, that makes so much difference. It really is an upstream condition that affects so many things downstream, even just attendance at physical therapy. I know, having been through physical therapy myself recently, it's just adherence to a PT program is so dependent on so many different factors at home, in the clinic, et cetera. And with transplant, so many things going on. With that in mind, one of the things that we're hearing a lot about, or I'm seeing in both popular medical press or in psychosocial press, at least, is a lot of emphasis on resilience these days. And I'm wondering if you could talk about resilience in patients that are facing these sort of challenges. Kind of two populations I'm curious about. One is the patients. What do we need to know about resilience? What sets patients up for success emotionally and psychologically? But then also, what would set caregivers up for success in terms of resilience from a psychiatric perspective as well?
So transplant can be a traumatic event, but also can be an event that leads to post-traumatic growth, exactly what you were saying, like building the resilience. And it is oftentimes, it's amazing to see these patients and families, how they deal with life-threatening conditions, life-threatening moments, because waiting for a transplant, it can have several moments of being close to death. Health-related behaviors are extremely important in this setting. Things that start with eating well, what kind of substances are used, adequate sleep, treating all the medical conditions, not just one. And the process of pre-transplant evaluations kind of encourages that and offers that, like almost like carries the patient. This is what you have to do to move on. Post-transplant, again, it's important to continue the health-related behaviors and look forward towards reintegration in society as soon as possible, but also to accept that it may differ than the pre-transplant role in society, because there may be some new limitations, but also some new strengths that one has built throughout this process.
Yeah.
For families, it's extremely challenging because it's very hard to plan. Oftentimes, these processes cannot be. There's very limited. There are very limited parts of it that can be actually planned, and the rest is a lot of be ready for the unexpected.
So kind of going to get into two last big questions for you here. One is, if I am a patient or a caregiver looking at a transplant situation. Well, actually, no, I'm going to step back. I have one other question before I get to that. In some of your writings, you've talked about Wilson's disease. You've done a very specific look into Wilson's disease, and you call it the Great Masquerade. I'm so fascinated by that, because we often see so many conditions, and liver diseases at the top of the list that are often, called as a cliche silent, or they're called, that they're hidden behind other symptoms or something like that. Talk a little bit about the Great Masquerade of Wilson's disease, if you would.
One of the challenges with Wilson disease, when it presents, so as you know, Wilson disease is a genetic disorder that ultimately affects the copper metabolism in the liver. So it's a liver disease. However, it manifests with neurological symptoms and psychiatric symptoms. And when it begins with psychiatric symptoms, which can cover all the spectrum of psychiatric disease, it often leads to delays in diagnosis, because Wilson disease is really not one of the first on the differential. Mm-hmm. And patients go through attempts at treating the psychiatric symptoms, which oftentimes involves weeks or months of trials of one treatment and then switch to another one. So very easily it can lead to delays in diagnosis. So luckily, we're learning more about that, and we have ways of, we're thinking now more about earlier diagnosis than, so hopefully the patients can get the treatment that it's needed.
Excellent. Okay, I'll go back to my question I was going to ask before I ask the other question, which is, if I'm a patient or a caregiver going into a transplant situation, outline my toolkit a little bit. What are the psychiatric, what are the mental health tools that I should be embracing as I'm going into this life-changing sort of situation? What would you suggest as tools to have to be able to rely on?
So I think the first advice or recommendation or guidance we give to patients is get to know who in your medical team matters, who are people, the key people, because these patients meet with a lot of medical providers, and it's impossible to remember all, and it can be very confusing to navigate, to know when I have a question, something's hurting, I need help, where do I turn? And also figure out a way of keeping track of all the appointments, interventions, medications, because again, it's a lot to remember, and it's extremely hard to know all this by heart, like without other help. In many cases, we encourage our folks to continue if they have a therapist that they know and who helps them, even if at some point they feel they don't need the therapist. This is a tough journey, and it's good to keep in touch with them, so you have somebody you can reach out if things get difficult. Another thing it's important is to tease out between what are things that can be predicted and what are things that could be expected at any time, because that leads to some life changes that are extremely important to have. So for instance, traveling when one is very close to getting a transplant may be extremely challenging, and because they're expected to be within a radius. So those are some of the things we kind of tell the patients to think about.
Great. So I'm going to drop this last question on you because I like leaving with our conversations with a little bit of hope, a little bit of looking towards the future. We have a International NASH Day coming up on June 8th with our slogan is Step Up to NASH. It implies taking the next steps on things that we can do. And your role as a transplant psychiatrist, you do a lot of research, you see patients, you're very, very involved in this sort of stuff. When you are, getting up in the morning or perhaps retiring in the evening and you're looking towards the next day, the next week, the next several years down the road, what is exciting to you? What gives you hope? What are the things that you look forward to in the field and for patients?
Well, probably one of the brightest moments on my work is when I help a patient right before surgery. After the surgery, I see the patient in the hospital. Then patient is discharged home. And then I go to the clinic in the outpatient setting to see, to get ready for the day. And I hear somebody calling me and I look at that person and I don't recognize who that person is, because the patient, it's a few weeks after the transplant. The patient is so much better, is now at home, is dressed casually, has gained weight, is smiling. And I don't recognize the same patient who was so sick. And that's probably that's the most rewarding moment. It happens quite a bit. So I tell my patients to keep the hopes up when things are rough, because that's what we're going to laugh at together in a few weeks or in a few months.
Brilliant, brilliant. Joining us today, Dr. Paula Zimbrand, the Director of Transplant Psychiatry and Associate Professor at Yale New Haven Hospital. Thank you, everyone, for tuning in. Look for us next week on GLI Live, and we will look forward to seeing you then. Thank you again, Dr. Zimbrand. A wonderful conversation. We'll look forward to working with you again in the future.
Thank you. Thank you for having me.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.